Greetings of the day, folks. Today we are going to discuss about the treatment of cellulitis. So the treatment in this general treatment and treatment for specifically purulent and non-purulent cellulitis. Okay, so treatment is elevation of the affected area to aid in like effective lymphatic drainage. So incision and drainage of any abscess found, and antibiotics for cellulitis. Okay, so antibiotics and treatment of underlying condition, these are the main features, like main uh, pillars of treatment in cellulitis. So elevation helps in drainage of edema. Treat skin dryness with topical agents because skin dryness and cracking further exacerbate the symptoms. Now, treat the predisposing conditions such as tinea pedis. Okay, now, for purulent, we are going to discuss about the empiric antibiotic recommendation. So, what are the empiric like in purulent? What are the what are the drugs normally? Whether it is a broad spectrum should I give, or we don't know yet. So let's dive into that. So it is guided by severity of illness, and here we find antibiotics, and we'll see the comments about that. So if there is disease is mild, if the cellulitis is mild, there is no requirement of antibiotics. So drainable abscess found with no signs of systemic infection, antibiotics none. Normally, immunocompetent patients should be able to recover upon themselves, so they do not require any antibiotic assistance. So presence of abscess should be carefully investigated clinically and drained. Consider ultrasound. Okay. So if the patient is having moderate disease, purulent cellulitis is there. Purulent cellulitis is defined as cellulitis with drainage or exudate in the absence of drainable abscess. Okay. In all cases of purulent, presence of an abscess should be carefully investigated clinically and drained. Bedside ultrasound can help occult abscess formation and verify complete drainage after procedure. So, or mainly in moderate disease with purulent cellulitis without signs of systemic infection or drainable abscess in the presence of mild to moderate signs of infection. So, in these patients, we give trimethoprim sulfamethoxazole double strength 1 to 2 tablets twice per day for 7 to 10 days, or doxycycline 100 milligrams per oral twice daily for 7 to 10 days, and or clindamycin 300 to 450 mg 4 times daily for 7 to 10 days. And wound culture is recommended in cases where antibiotics are given. Patients who have failed to improve on outpatient antibiotics or are unable to tolerate oral antibiotics should be admitted to hospital and receive IV antibiotics. Okay, so in case of severe disease, IV antibiotics are recommended. So for purulent infection cellulitis, as we have already discussed, which cannot be drainable. Okay, so purulent cellulitis with signs of systemic infection or drainable abscess in the presence of moderate to severe signs of systemic infection or sepsis, or an immunocompromised state. So if you see here, immunocompromised state should be also be considered in the severe category. So in the for MRSA coverage, we try to administer the patient with vancomycin 15 mg per kg IV every 12th hourly, linezolid 600 mg IV 12th hourly, or daptomycin 4 mg per kg IV 24th every once daily, telavancin 10 mg per kg IV 24th hourly, and clindamycin 600 mg IV 8th hourly. Okay, so optimum treatment duration has not been established, but for mild to moderate 5-day oral treatment regimens have been successful, but are recommended only in settings where follow-up is feasible. So okay, so admit first, patient should be admitted because it is severe, categorized as severe, and additional antibiotics should be given, and consider admission to ICU for patients who meet criteria for sepsis, as we have discussed in other videos. So for all patients with severe disease, see for all, like we'll go in the later on add-on videos, we'll see look after the necrotizing part. Okay, so additional coverage for patients with sepsis or for patients with selected indications. So for them we will include broad spectrum like piperacillin and tazobactam 4.5 grams IV every 6th hourly, or meropenem 500 to 1000 every 8th hourly, or imipenem cilastatin 500 mg IV 6th hourly. For freshwater exposure, which may be having like Aeromonas species infection, or saltwater which may have Brio species infection, we may add we must add doxycycline 100 mg every 12th hourly plus ceftriaxone 1 gram every 24th hourly. Okay, so this is what the empiric antibiotic treatment is given in purulent cellulitis. So we will continue with the paragraph. So identify and so we have covered the antibiotic section thoroughly. Then we should identify and thoroughly drain an abscess. Focus will aid in this procedure and provide empiric therapy for MRSA for patients who have failed initial non-MRSA therapy. Those with previous history of or risks for MRSA, or those who live in an area with high prevalence of community-associated MRSA infections. For patients with severe infection or systemic toxicity, consider necrotizing fasciitis. It may be difficult to clinically distinguish MRSA cellulitis from MRSA methicillin susceptible Staph aureus cellulitis. Treatment failure rates are similar for both beta-lactam antibiotics and MRSA-specific antibiotics such as trimethoprim sulfamethoxazole. Treatment of non-purulent cellulitis. Guidelines no longer differentiate treatment of non-purulent cellulitis from erysipelas. Okay, this is one of the most important new guidelines are showing that there is no differentiation in the treatment aspects. So oral antibiotics are sufficient for simple cellulitis or erysipelas in otherwise healthy adults. In cases where there is no evidence of drainage or identifiable abscess, empiric MRSA coverage is not necessary. Focus to confirm lack of an abscess is highly recommended. MRSA coverage should be considered in patients who are diabetic, immunosuppressed, have a peripheral vascular disease, or have a history of IV drug abuse, or require hospitalization. So we'll look after another table. So if there is any bullae, crepitus pain out of proportion to examination, or rapidly progressive erythema with signs of systemic toxicity, because it suggests necrotizing, must be ruled out. Okay, so we will look after the antibiotics in non-purulent cases. Okay, non-purulent cellulitis or erysipelas. Okay, if the exudate non-purulent is if exudate or abscess is found on exam, patient should be treated for purulent. Okay, optimal treatment has not been. Okay, let's see. So for the oral, this is also guided by severity of illness. So in mild cases, typical cellulitis or erysipelas with no focus of purulence, no signs of systemic infection, we can discharge the patient with cephalexin 500 mg per oral every 6th hourly, or dicloxacillin 500 mg every 6th hourly, or clindamycin 150 to 450 per oral every 6th hourly. So cultures are not recommended because of poor yields, and also consider MRSA coverage in patients who are diabetic. Okay, so or immunosuppressed, or have peripheral vascular disease or history of IV drug abuse, or require hospitalization. And in case of moderate therapy, moderate disease, we may administer patients with monotherapy IV antibiotics. Like in this typical cellulitis or erysipelas, there were mild to moderate systemic signs. There is mild to moderate systemic signs, and if immunocompromised patients are there, they must be included in severe category. So in moderate disease, the patient can be administered ceftriaxone 1 gram IV 24th hourly, or cefazolin 1 gram IV 8th hourly, or clindamycin 600 mg IV 8th hourly. So patients who have failed to improve on outpatient antibiotics, or are unable to tolerate oral antibiotics, should be admitted to the hospital and receive IV antibiotics with coverage dependent on severity of illness. And now coming to the severe disease, including necrotizing fasciitis, broad spectrum antibiotics for severe disease, those with sepsis. Sepsis is hash marked. So hash is criteria for sepsis in the presence of infection or two or more of the following, like temperature more than 38 degrees centigrade, tachycardia more than 90, tachypnea more than 24, WBC less than or equal to 4,000 or more than equal to 12,000 or immunocompromised state. So if the patient is having those with sepsis or those with clinical signs of deeper infections such as bullae, skin sloughing, hypertension, or evidence of organ dysfunction or an immunocompromised, patient should be administered a broad spectrum which includes vancomycin 15 mg per kg IV 12 hourly plus piperacillin tazobactam 4.5 grams IV 6 hourly, meropenem 500 to 1000 mg IV 8 hourly, imipenem 500 mg IV 6 hourly. Consider immediate consultation with the surgery for further possible debridement. Blood cultures recommended in this treatment group. So now different or additional coverage for like patients with selected indications. If there is exposure with this all freshwater exposure, then we can add patient with doxycycline 100 mg IV is 12 hourly and plus ciprofloxacin IV 500 mg every 12th hourly. If there is saltwater exposure, he might just require doxycycline and ceftriaxone 1 gram IV 24th hourly. Okay, and in cases of suspected Clostridium species, which is an anaerobic organism, so we may add the anaerobic coverage, that is clindamycin 600 to 900 mg IV 8th hourly plus penicillin 2 to 4 million units IV 4th hourly. So consider immediate consultation with the surgery for possible debridement. Okay, so we have completed the treatment of non-purulent cellulitis or erysipelas. Now coming to the discussion, admit patients with cellulitis or erysipelas and evidence of uh, systemic toxicity and those with underlying comorbidities such as diabetes, alcoholism, immunosuppression. And healthy patients without systemic toxicity can be discharged to home with close follow-up within 2 to 3 days. Mark the patient's skin with an indelible marker along the perimeter of the so healing can be determined at the follow-up. Indelible, okay, marker. Marks also aid the patient in evaluating the worsening infection. Reported risk factors for failure of empiric antibiotics include fever, lymphedema, or chronic edema, chronic leg ulcers, prior cellulitis in the same area, and cellulitis at a wound site. Okay, so this is what the disposition is. So this concludes our